I have no financial interest. It is standard disclaimer. As we heard in the previous talks that there is always a confusion whether to have medical treatment, early surgery with without MMC or with other things. That confusion gets solved and you do surgery. And AC is flat on day 1 and the patient and the surgeon is like this, crying and consulting others despite the fact that he is a well-known surgeon. So what are we scared of? The two things, the leak and malignant glaucoma. Rest of the things are innocuous. So these are the ideal things that we want to see on the first 2-3 post-operative days. Slightly shallow AC with IOP of 6 to 10. Early and late post-operative appearance, that is what we desire. So the AC can be flat or shallow with elevated IOP or with low IOP. With elevated IOP is uncommon, but it does happen, and can be ciliary block glaucoma or suprachoroidal hemorrhage. Retained visco is a rare possibility. And with low intraocular pressure, it can be overfiltration, which is innocuous, wound leak, little more dangerous, choroidal detachment, which is generally the effect and not the cause of hypotony. There are other reasons too. Incidence of overfiltration as well as leak has increased due to use of antifibrotic agents. However, lately in the last few years, releasable sutures have become very common and they have reduced this incidence. Grade 1 and 2 are the peripheral touch. These are innocuous and can be managed medically, whereas grade 3 of the shallow chamber is the iridolenticular touch. It is a surgical emergency. The principles of surgical treatment for grade 3 is that it can lead, this is actually required because this is a surgical emergency because it can lead to cataract formation, anterior and posterior synechiae, as well as endothelial cell decompensation of the cornea, not within days but within hours. The immediate treatment is AC reformation with air in case of leak and viscoelastic in the cases of overfiltration. It is done immediately in the clinic on slit lamp. However, resuturing can be planned better in the OT at an appropriate time. So, the bleb leak, the intraocular pressure is generally 0 or maybe up to 6. Anterior chamber is shallow, the bleb is shallow or flat, and the diagnosis is confirmed by CDOS test, which you can see here. And the site is generally a conjunctival suture or an area of conjunctival buttonhole. The treatment can be conservative. You stop the topical steroids and start oral so that inflammation is not there. Gentamicin, tobramycin, these are fibrotic drugs. They cause fibrosis, so they help in reducing the leaks. Atropine is mandatory in these cases. Pad and bandage can be given. Large bandage contact lens can be tried, but generally they don't work. Autologous blood injection again is not my favorable, although described. The treatment can be either laser or surgical as well. Argon laser photocoagulation using large spot size after staining the area of leak with gentian violet or trypan blue can be done. 500 is the minimum size that we need to use, or we can use even 1000 micron. The suture removal can sometimes be required because between the two layers, between two raw surfaces, you need to have a direct contact. Sometimes a suture pops up in between and it does not let it heal, and removal of suture may help you to heal the leak. Of course, resuturing is the final answer. The distal edge of conjunctival leakage sometimes can be at the limbus, and in case you are suturing at that time, please remove the epithelium from the cornea because suturing will have to be done conjunctival corneal. It may require lens removal if cataract has already formed if the shallowness persists, and this is what it is, cataract developing within hours. Excessive healing of topical steroids, the problems related to bleb leak are multiple, and all of them ultimately lead to bleb failure, as Dr. Das had described in his introduction. Hypotony maculopathy is less common in leak. It is more common in overfiltration because a sufficiently long period for it to persist is required. A low intraocular pressure will always have a tendency to pull the things from the surface, leading to endophthalmitis. The hypotony due to overfiltration, it's unlike bleb leak. It's generally the bleb is generally raised and not flat, and it is relatively innocuous. As I said, settles on its own, can cause significant hypotony maculopathy. Hypotony maculopathy is more common, as I said, in overfiltration rather than in the leak. So this is what you can see, elevated bleb with shallow AC in overfiltration. The treatment is mostly conservative with oral steroids and atropine, and one may need to inject intracameral viscoelastics for this. And argon laser photocoagulation from the sides can be done if the bleb is very large. The final answer is the surgical, that means the tightening of the scleral flap, but it generally will lead to failure. The Pomberg suture usually must have a scleral bite, which is practically very difficult to give because otherwise the suture will not work unless you have taken sclera into the bite. Ciliarochoroidal detachment may be cause or more likely effect of hypotony, as I said, may be subtle and hardly visible even on UBM. However, it can be as large as kissing choroidals. Reduced visual acuity may be a very, very early sign. If a patient post-trabeculectomy comes with a reduced trabeculectomy, generally you have a small ciliary detachment which you will not be able to detect unless you do a UBM. Generally settles on your own, on its own with steroids, topical and oral, as well as with atropine. If it does not settle in 2 weeks' time, that means you need drainage. The flat AC with elevated intraocular pressure can be pupillary block or malignant block, or it can be suprachoroidal hemorrhage. The diagnosis can be confirmed by ultrasound. The expected elevated of IOP in the first 2 to 3 days is the expected pressure is 6 to 10 millimeters of mercury in an ideal trabeculectomy. So in case the pressure is 14, 15, 16, it may be a normal range, but it can still be malignant glaucoma. So there are 2 mechanisms which can be differentiated by UBM. First is it can be caused by ciliary body detachment and anterior rotation of the ciliary body. AC here is flat and lens iris diaphragm is rotated forwards, causing mechanical angle closure. The treatment in these cases is medical and surgery only if it fails, and the surgery is suprachoroidal drainage. The second, which is the most dreaded complication, which we all actually talk about malignant glaucoma, is the aqueous misdirection without ciliary body detachment. Here the AC is flat and lens iris diaphragm is rotated forwards, causing mechanical angle closure, and the treatment is surgical, that is the rupture of anterior hyaloid face or drainage of the aqueous which is collected on the back side in the vitreous. So it is more likely in chronic angle closure glaucoma where there is no PI done preoperatively, and it can present soon after surgery or when cycloplegics are stopped. If one patient has suffered from this, the other eye is also likely to have the same problem. This is very, very important. And prevent in the other eye by using preoperative reduction of intraocular pressure as well as blood pressure and postoperative use of very strong cycloplegia. Here you can see the aqueous pockets in the vitreous which may sometimes be visible and may require drainage if required. This is a case of ciliary block glaucoma following cataract surgery, which I wanted to highlight that it can happen not only after trabeculectomy but after other intraocular surgeries as well. So the treatment is medically in 50% of the cases, and something I want to highlight is a cycloplegia which is required in these cases very strong. Atropine what we have available in the market is 1%. However, we may need to make from the injectable as 2, 3, 4% and add to this phenylephrine so that we can have the maximum cycloplegic effect. The lasers can be used in this to open up to do the anterior hyaloidectomy in case the patient is pseudophakic, and the full surgery means the aspiration of the fluid using 18 gauge needle on 2 ml syringe passed through pars plana after making sclerostomy. For this you have to see the fluid cysts on ultrasound B scan, otherwise you may not be able to do this. Or otherwise, if everything fails, then vitrectomy is the answer, and occasionally you may even need to do lensectomy. Thus, to summarize, post-operative Flat AC is a serious complication of incisional surgery for glaucoma. Mostly one of the 4 reasons of the flat AC are there, and 3 are with low and 1 is with a high IOP. IOP decides whether it is malignant glaucoma or otherwise. Most cases can be managed conservatively. Iridolenticular contact is a surgical emergency. Although YAG laser capsulotomy with anterior vitreous face break may help in pseudophakic, vitrectomy may be required in malignant glaucoma. Eyes with malignant glaucoma may require lifelong atropine. This is very important. They may require lifelong atropine. The fellow eye is at high risk of malignant glaucoma, and prevention is the key to success. Thank you so much for the patience.